chairpersons for giving me this chance again. Thank you. So as we have discussed, this is a case of 18 weeks uterus with previous two LSCs. I have shown you already the IR stents. See the relationship of the ureter to the broad ligament. So this is a left posterolateral broad ligament. Just I have already opened up the, you will pull the other side. So that is a thick peritoneal band actually, not the bladder, that is adherent to the previous uterine scar. So I am using a harmonic to dissect the bladder down. Just create lateral window on both sides. Identify the plane. Do it. This is a uterine artery I am taking care of, the broad ligament. Then after hysterectomy, I have separate here. I have enucleated the fibroid, took out the uterus through the vagina, and morcellated the specimen fibroid. See, I have separated the fibroid from the uterus, took out the uterus through vagina, and morcellated the specimen fibroid. So we are not lucky always. Sometimes the bladder is very much densely adherent. This is a case of previous two cesareans and one hysterectomy. The bladder was densely adherent to the previous uterine scar. I always go through a lateral approach. Just create a lateral window below and medial to the uterine vessels. See the difference. You can with experience you will get that identification, visual identification of the bladder tissue and the cervical tissue. And the pattern of vessels, how they go on the cervix and on the bladder. By that you can identify which one is the bladder tissue and which one is the cervical. See, from both sides have created lateral window, and from lateral window on one side to the other. This is with anterior wall fibroid that is obscuring the view. So just give a traction on the uterus. See that glistening white tissue is the cervix. Okay. Slowly identifying the plane from one lateral window to the other lateral window. So here you can see, so that is the plane. Just put one of the plates of the harmonic in one lateral window, then go on to the tissue, either with a cold scissors or a harmonic, you can do this. That is the bladder and that is the cervix. You can see the vaginal colpotomizer there. So identify the planes from the virgin area, that is both sides laterally, and then take care of the tissue. See, that is the bladder, and go as above and as nearer to the uterine scar as possible. Okay. So whatever the small bladder supertissue fibers are there, you can just take care of them. Don't head on to the bladder, just go nearer to the scar and just give a cut, either with the scissors or a harmonic, and the bladder goes down. So that is the colpotomizer, you can see. Even if the lateral window is not possible, you can just open the round ligament, cut the round ligament as lateral nearer to the side wall as possible, and then go posteriorly, identify the uterine arteries, skeletonize the vessels, then go posterior to the vessels. If the lateral window is also not worsened, in the case of PIDs, you can go posteriorly, identify the vessels, and then come anteriorly. Two sections. This is a ventrofixed uterus. See, I am putting the camera, the uterus is not seen, it is completely adherent to the anterior wall. Even the tubes and ovaries are also into the anterior abdominal wall. Just take care of the omental adhesions. Be careful to watch for any bowel adhesions. Just show you this. See, after dissecting the omentum down, just see for the round ligament always. First identify the round ligament, then do a horizontal dissection at the round ligament from the corneal to the lateral side wall. Always identify round ligament, horizontal dissection from the corneal end to the these are like, it is like finger-like bands by which the uterus is adherent to the anterior abdominal wall. Identify the round ligament, dissect it down, then go into the vertical direction. So first horizontal from the corneal end to the lateral pelvic wall along the round ligament, then go in the vertical direction, create paravesical spaces on both sides of the uterus, then pass an instrument between the dome of the bladder. I will show you that. So between the dome of the bladder and the uterus. See, just pass your instrument from one side to the other side. Then you will confirm that the bladder is down below your instrument. Then cut above the horizontal instrument. You take another and then cut the bands. So that is in case of a ventrofixed uterus. So this is another case of again a ventrofixed uterus, more densely adherent than the previous one. So take out this. So posteriorly also it is adherent. It is a combination of adenomyosis and that I will show you after this. So the same case I have already done hysterectomy. Whatever I was shown you in the second ventrofixed uterus, hysterectomy is done. Then I identified a ligament-like structure. So I just cut hold of that ligament-like structure and then I am surprised to see a free fibroid down over there attached to the mesentery of the sigmoid column. See, I have dissected the mesentery down and digging. Finally, it is like taking out all the adhesions from the fibroid. And finally, you see it is almost a 6 by 4 centimeters fibroid, it was not seen while doing hysterectomy. So these are the surprises we see in previous, maybe a multiple fibroid uterus with previous sections. See finally how big was the fibroid, it is 6 by 4 centimeters. If we miss this, again the patient will come with symptoms and ultrasound, they will say the fibroid is there and patient will have it out whether we have done hysterectomy or not. Right? So this is a case of again with multiple fibroids. Posterior, they have given like first they have on ultrasound the findings were like there is a intracervical mass in the cervical canal, hard mass in the cervical canal. Then I have ordered an MRI and MRI says it is a cervical fibroid which is going into the cervical cavity, occupying the cervical cavity. So first I took care of the triple ligament, then the uterine artery, then I can see I am just opening the plane of the fibroid, the capsule of the fibroid, and then dissected it down. I found major feeding vessels, just dissecting it down. So this is the attachment of the fibroid. Actually this is also, I can't say whether it is completely a cervical fibroid or not. So this is not occupying the cervical canal, nothing. It is actually a broad ligament fibroid attached to the posterior surface of the cervix. I believe we can't differentiate whether it is coming a subserosal fibroid from the cervix or a broad ligament fibroid attached to the cervix. So finally I have dissected it, separated it down from the uterus. So did hysterectomy. After that I have separated that from, see, I am opening the capsule, it is coming out. Then that is the bed of the fibroid, lateral to the posterior wall of the ward. So this is the case of cervical fibroid. Again the same finding they have given. On putting the camera, the cervix is on perspective examination also the cervix is not seen. On putting the camera laparoscopically also we can't see the fibroid. It is down below the uterus sacrals. I couldn't place even the uterine elevator. So just by traction with the other instrument, approached till the uterine arteries, then opened up the capsule of the cervical fibroid, then separated, then hold it with a myoma screw, lifted the fibroid. So here it is actually going into the cervical canal. That is the down one is the uterus and this is the fibroid. It is bigger than the uterus. See, on opening this, that is the uterus fundus, you can see down. So on opening, this is actually going into the cervical canal, and after putting the myoma screw, then I kept the uterine elevator. Now you can see the sound of the uterine elevator. See, that is the opening of the cervical canal. Okay, then separated the fibroid. So in these cases, actually broad ligament and cervical fibroid, you can go for a preoperative uterine stenting also. So now you can see the anatomy of the uterus. So that is the uterus, and that is the base of the cervical fibroid, which is going into the cervical canal. Instrument. I approached till the uterine arteries, then opened up the capsule of the cervical fibroid, then separated, then hold it with a myoma screw, lifted the fibroid. So here it is actually going into the cervical canal. So that is the down one is the uterus and this is the fibroid. It is bigger than the uterus. See, on opening this, that is the uterus fundus, you can see down. So on opening, this is actually going into the cervical canal, and after putting the myoma screw, then I kept the uterine elevator. Now you can see the sound of the uterine elevator. See, that is the opening of the cervical canal. Okay, then separated the fibroid. So in these cases, actually broad ligament and cervical fibroid, you can go for a preoperative uterine stenting also. So now you can see the anatomy of the uterus. So that is the uterus, and that is the base of the cervical fibroid, which is going into the cervical canal. Specimen retrieval, we were discussing there are many options for this. Preferably vaginal, we can do morcellation, coring of the specimen, or you bisect the uterus, or you take a combination of bisect uterus and unucleate the multiple fibroids. If it is an adenomyosis, you can core the uterus. If it is not possible, then go for a power morcellation or a suprapubic incision and you can take it out. So these are the various specimens. This have unucleated the fibroids. It is a 22 weeks uterus. Just by unucleating the fibroid, I could take out the complete fibroid without morcellation, even vaginal morcellation. I took it out completely. And then the other thing, you can see the multiple fibroids. I have bisected the uterus, then unucleated the fibroids, and the bigger fibroid also you could take it out intact without any vaginal morcellation. These are by bisecting and all. If not possible, then go for power morcellation. If at all power morcellation, contained morcellation is always safe. So this is another surprise actually, like the last one, a broad ligament fibroid. So after doing a hysterectomy for ventropixid uterus, later you can see there in the second slide, there is a subserosal fibroid in the anterior abdominal wall. So just I was about to suture the wall, then I could see something. I am not getting the view of the wall down. So I thought something is there. I just palpated it out. It was hard. So I thought something is there. I just gave an incision on the peritoneum, the anterior abdominal wall. Then I could see a 2.5 by 2 centimeters subserosal fibroid in the anterior abdominal wall. So always careful preoperative evaluation, adaptable intraoperative decision making, meticulous dissection, identifying the structures and tissue mobilization techniques are the key for facing the challenges in the difficult TLH. So what we repeatedly do, then excellence is not an act, but it becomes a habit. Thank you so much.